Good morning. It's my pleasure to introduce our honored guest, Dr. Fred Barker. He's professor and vice chair at Massachusetts General Hospital at Harvard. He obtained his undergraduate degree from Yale with a focus in molecular biochemistry and classical civilization. He then went to Harvard Medical School. During that time, he followed that with a fellowship at Mass General, a residency at Mass General, followed by fellowships in Pittsburgh with Peter Janetta, which gives us some connection, and also Dr. Wilson at UCSF, focusing on surgical oncology. His service in neurosurgery is well known. He is the president of the Academy. He is the editor of the Journal of Neurosurgery. And he is currently a professor and vice chair at Mass General. It's a real privilege to have you here, Dr. Barker, and we're delighted to hear you speak this morning.
Thanks, Ray. Now, just give me a second to see if I can understand how to do this. So, like Mike Wang yesterday, I did not get into Columbia. I did not get into medical school. My father was a surgeon. My uncle was a surgeon on staff at Columbia, Harold Barker, for 50 years. And not only did I not get in, I did not get an interview, and I never even got a rejection letter. And as I had paid my $150, and the summer wore on. Every other place had either taken me or rejected me. And I said to my dad, like a fat lot of good your brother has done me. I never even got rejected. It was August, and about 2 weeks later I got rejected. So it was clear that my family connections had only been good enough to get me rejected, that they hadn't even looked at my application. So I've always felt like Columbia owed me $150. And I'd like to thank you for having me here today, because it repays that debt and much more. So I'm going to talk about stuff. I'm going to try not to talk about the future, but just about what we do now in the clinic, because it has changed so much in the last couple of years. If you think about the war on cancer as it has gone since the 70s, before 1960, you had Halsted, radical mastectomy, things like that, ways to take tumors out, and then oncologists worked out cytotoxic chemotherapy like BCNU for glioblastoma, fractionated external beam, which was only really proven effective in glioblastoma in the 70s. And then people got better, a sharper radiation, less scattered to normal tissues, the proton beam, radiosurgery, stereotactic targeting of both surgery and radiosurgery. And then the rest of cancer really moved ahead of us, because in 2002, the first reports of imatinib for leukemia came out, and in 2005, imatinib turned out to be effective for GIST, and a bunch of other solid tumors followed. And I was in the audience when this was presented. It was amazing to watch 40,000 oncologists watch their entire career just suddenly change on a dime. It was like watching the first report of penicillin for pneumonia. It was so much better than what they had been doing before. And then within a few weeks of that, just down the hall from me was the melanoma program, and they had people coming in who were effectively just about dead. And they would give them these new drugs, and within a month they would be out playing golf. And I said, well, like, when are we going to get this? And we never really did. Erlotinib was one of the most promising, this is Tarceva, one of the most promising targeted agents, tried on glioblastoma at recurrence, and you see that the survival was actually shorter in the erlotinib arm, as in addition to a lot of toxicity. And the reason is because glioblastoma is not one tumor. It's a whole bunch of tumors, 100 tumors or 1,000 tumors. And if you have a targeted agent that kills all those yellow cells, all the green ones and the blue ones and the red ones just thank you for making more room for them. And you can't block every pathway in the entire human body. So glioblastoma still remains a very difficult problem. And although I spent a lot of time thinking and working on glioblastoma, it started to occur to me that there were all these other tumors that neurosurgeons carry the primary responsibility for that the oncologists never even see. And nobody was really working on translating the advances in oncology to these populations where we are the main doctors. So to start with NF2, my colleague Scott Plotkin, who was a young neuro-oncologist who inherited the neurofibromatosis program at Mass General when the previous doctor went to Oregon to train service dogs, and he didn't know anything about it. Every week he would bring me cases and say, look, this acoustic neuroma is growing, you have to take it out. And I would say, well, what's the hearing like? And it was the only hearing ear. I said, I'm not going to take that out. Well, what am I supposed to do? Can I give them radiation? No, you can't give them radiation. What am I supposed to do? I said, you need to find a drug that is effective treatment for the whole body because they have multiple tumors. But the problem is NF2 is an oncogene, so it's a tumor suppressor, not an oncogene. So every patient, every family has a different mutation, and theoretically you might need to have a different drug for every cohort. And meanwhile, the graph on the left shows that if your age at diagnosis of NF2 is less than 19, that the odds are that you'll be dead before you get to age 30. So this is as bad as many cancers. It's as bad as breast cancer if you have really bad NF2, in addition to the crippling neurological effects. And so we got a meeting together with a bunch of oncologists and patient support group members and so on, and said, what should we do? And there was a lot of argument, well, there's this pathway, there's that pathway, we should try aspirin. And the patient support group people at the end said, we don't care what you do, just do something. Start treating something. We don't understand why you're not doing something. So he picked erlotinib because people were using it for glioblastoma. And he had this one guy who was in Italy. I guess I don't really have a pointer here, but you see that hearing stability that goes way over past a year there. That was one guy in Italy who wasn't really getting a complete audiogram. And it was pretty clear to me that this was not doing anything, but I didn't want to discourage him. And every time I asked him about it, he's talked about this guy in Italy. And then one day I said, how's the erlotinib going? And he goes, I really have decided that it doesn't do anything. I said, well, what are you going to do next? And he said, well, I've already started giving some people Avastin, bevacizumab. And I said, that's nuts. You cannot do that. I mean, these are people who are going to live for decades. You can't give them Avastin. You don't even know. That was designed for people who are going to be dead in a year. And you don't know what will happen. Their skin might fall off. Their heart might stop working. And he said, well, but one of them says that her hearing has gotten better. And if you've treated patients with NF2, this never happens. So she went from, this is her only hearing ear, she went from functionally deaf to normal hearing in about 6 months. And so I took this to my otologist, and they said, well, Fred, that's really great. Like when your 2-year-old says that she's going to have ice cream for dinner every night. That would be really great, but that doesn't really happen. We understand the physiology of this very well, and that can't happen. And 2 or 3 of them told me that almost in the identical words, but it did happen. And it happens not to every patient, but these graphs here, the green, are people whose hearing had a positive change on bevacizumab treatment, with the word recognition score being at the bottom and then the arrows showing where it ended up. So that second one, third one from the left was patient 2 that I showed you, who went from 8% to 98%. And relatively modest differences in word recognition score, if it's your only hearing ear, are very important in daily life. So these people become much more functional. And when we sent it to the New England Journal, we had about 3 months follow-up. And a couple of scientists criticized our immunohistochemistry and weren't really very enthusiastic. And then a couple of reviewers were clearly clinicians, and they said, thank you very much. We're going to start treating patients with this tomorrow. And so the New England Journal said, well, your patients, none of them have even been treated for a year. We need to have a year follow-up at a minimum to see if this response is durable. And meanwhile, if anybody else publishes it, we're not taking it. So it was like a ticking time bomb because Scott had been going to conferences all over the world and telling them about this. And in fact, it came down to a race between us and a German group that was going to publish in Neuro-Oncology. But in the end, we got it published. And this is in daily use in our clinic. And the most of the use is for people whose only hearing ear is threatened either by tumor growth or by decreasing hearing. But it has some other uses as well, like cervical ependymomas that are symptomatic, which is unusual in NF2. We'll treat with that. And we've always said that if we had somebody who was deaf in the other ear and they had an acoustic threatening hearing in the only hearing ear, even if it wasn't NF2, that we would treat them. But that doesn't really come up. Nowadays, the other ear can usually have hearing restored with a cochlear implant, for example. And it's a pretty uncommon clinical situation. But if it happened, I think we would use it for that too. And it turned out that these responses that Scott had are in fact extremely durable, and people can survive 10 years of bevacizumab treatment. We have many patients who've been treated for more than 10 years. Sometimes they get hypertension or difficulty with renal function, and they need a drug holiday for a few months. But then when you start it up, you get the response back again. And the effect, when you have a treatment that works, what happens is that the other treatments start to go out of business. And so you can see this graph. This is from the nationwide inpatient sample. The number of NF2 acoustic operations between around the year 2000 and around the year 2020 has fallen by more than half. And of course, a lot of that is due to radiation. But on the right, you see sporadic acoustic neuroma operations during the same period. And after the radiosurgery decline, that has actually hit a nadir and is going back up again. So I think that some of this, and the Manchester group, the largest group in Europe, tells us that they basically don't do pediatric NF2 operations anymore. And I would say it's the same for us. But it has some unintended consequences. So what happens is these people who have hearing, they've had often an operation on a small tumor on the other side, and hearing loss is not very well correlated with tumor size in NF2. So all of these patients are all in their 20s. They all have 5-centimeter acoustics, and they all have hearing in that ear and nothing on the other side. So now what? So I don't know how many patients. I've done about 1,200 acoustics, and it seems like about 1,000 of them have been told by somebody, like Dean was talking about, that your heart was going to be crushed. They've been told that the tumor is touching the brainstem or compressing the brainstem, or it's about to touch the brainstem. And they're terrified of that, like they're going to drop dead the day that that happens. But only about 0.5% of people that I've seen with acoustics over the years actually have symptomatic brainstem compression. And this is what it looks like. The brainstem is completely moved over to the opposite side of the head. And symptomatically, it looks a lot like NPH. They get the same kind of shuffling gait, the same short step, wide base, loss of balance. They have falls. They get both urinary and fecal incontinence. And the distinguishing feature is that they can't swallow safely, that they aspirate. That doesn't really happen in NPH. They'll often have some dysmetria on the side. If it's on the right, they can't sign the surgical consent. None of these patients have hydrocephalus. None of them are shunted. And they don't get the memory disorder. But you have to do something. And surgery for these is kind of a harrowing experience. First of all, it's kind of depressing to come to work to make somebody deaf. And the patients are depressed, you're depressed, everybody's depressed. And then, I don't know if you can see those internal vessels on the left-hand panel, and then the two arrows in the middle panel, that is a draining vein from this tumor, and it is bright red. And I got into it right at the start of the case, and 2 liters of blood and 6 hours of microsurgery later, I had a not too embarrassing subtotal resection, and we stopped there. But it was not a good way to spend a day. And it turns out that the bevacizumab treatment, for whatever reason, either tumor size or something intrinsic about the treatment itself, that these tumors have more hemorrhage at surgery, more blood loss. The usual NF2 case is almost avascular, but these tumors are a totally different animal. What can we do besides surgery for these, besides surgery and radiation? One of the biggest advances that I've seen during my career is actually in rehabilitating the deficits that we create as surgeons. So facial reanimation has used to be that they just put some fascia in here and gave the patient sort of a rictus smile, and then after a while it would kind of ease down to normal appearance, but there wasn't any dynamic restoration of facial movement. And now there are several ways of bringing good facial movement to a paralyzed face. With the eighth nerve, of course, with technology, now you can get a cross hearing aid that sends the sound from the deaf side to the good ear by Bluetooth. And cochlear implants are an area of active development in acoustic neuromas. And for these patients with the large tumors who don't have cochlear nerves anymore, the auditory brainstem implant. So the result of that is typically sound perception. Most people have sound perception, but not word recognition. About 10% get good enough word recognition that they can use the telephone or understand speech without lip reading. And then one of the main ways that NF2 patients die is vocal cord palsies on both sides. We do laryngoscopy before and after every NF2 operation, and we have specialists from the eye and ear who can fix almost anything nowadays that happens to the vocal cord. So here's an example of reanimation of the face. That face is completely paralyzed, this 14-year-old. And the masseter motor branches have been transferred to the facial nerve, and he has actually a pretty symmetrical smile. It's going to need more done to restore tone to the face, and you can see he still has the weight in the eyelid, but that's a big improvement, particularly at an age when people are very sensitive to their appearance. So where are we supposed to go next with this? I mean, bevacizumab is not specific for NF2. It's just coincidence, really, that it works. A general principle is that if you don't have 10,000 patients or so who get the cancer in the United States, drug companies don't want to hear from you. And NF2 is just not a big enough market that anybody cares about it. However, the only other systemic cancer that has NF2 mutation as a common driver is mesothelioma, for which there's a ton of money for research because I think of the asbestos settlements. And it turns out that just about everything that drives mesothelioma also drives meningiomas that have the NF2 mutation. And if you think about it a little more, mesothelioma is a tumor of the serous lining of the fluid cavity around the lung, just like meningioma is a tumor of the serous lining of the fluid cavity around the brain, or of the abdomen where people get mesotheliomas, or in the sheath of the testis where people get mesotheliomas. So it kind of makes sense. So I was talking to my colleague Brian Choi, and I said, you know what, we ought to, you are a guy who makes CAR T cells. Why don't we make a CAR T cell against mesothelin? Because there was a paper from UCSF from the 1980s that said that meningiomas express mesothelin. And he said, well, there already is one. They developed it for pancreatic cancer. It's already been through human testing. And if you use it on mice with xenografts of human malignant meningioma, the meningioma goes away and the mice have long-term survival, as you see on the lower left. So if we can get $10 million, we have the next thing to try against meningioma in hand. But that's not targeted therapy. That's still not targeted therapy. Where are the targeted therapy successes? So the first one was in 2010, everolimus for tuberous sclerosis. And not only does it work, but this group was smart enough to build in patient important endpoints, like do their learning disabilities get better? And we learned from that when we designed our subsequent trial. And that's in common use. But we were still on the lookout for some kind of brain tumor where there would be existing cancer drugs that we could just pirate and use. And the first one that came along was discovered by Priscilla Brastianos when she was a neuro-oncology fellow at the Brigham, when she did molecular subtyping on adamantinomatous and papillary craniopharyngiomas. And it turned out that the papillary group, 95% have the same mutation that caused those dramatic melanoma responses that I showed you on that PET scan from 2008. And there's almost nothing else that's wrong with craniopharyngiomas. They don't have a lot of other mutations that will drive the tumor if you were to abrogate the BRAF signal. So it took us about a year to find our first patient. This was a guy who, not a U.S. resident, lived in New Hampshire, had no medical insurance, and he would come to the Mass General to get his papillary craniopharyngioma taken out because he was in a coma, and then he would go back to New Hampshire, and he couldn't get radiation to the residual tumor. His first resection had been in the Dominican Republic, and he went through this cycle 4 times. And the last time, me and Dan Cahill spotted this guy and said, here's our first patient for BRAF-MEK. And that was what we did. We admitted him to the hospital, and instead of, he was on the surgery schedule for Will Curry, but we started giving him dabrafenib and trametinib. And the hospital, I've never seen the hospital so angry, because here we had this guy as an inpatient for tablets that he was taking by mouth, and it was costing the hospital about $500,000. And we got a call every single day from the chief medical officer telling us we had to discharge this guy, and we just kept not doing it. And at the end of a month, there was only about 15% of the tumor left, and then Will did his delayed operation. We did not find any resistance mutations at the second look surgery, and by then, social services had found a place in New Hampshire where he could get radiation. So it was not a gross total resection in the end, but with the radiation, he's been stable ever since. And that was enough for us to get a national trial open. Eva Galanis was the head of the neuro-oncology group in the Alliance Cancer group at that time, and she was on board. And so we treated 16 patients. 1 patient got a drug rash and didn't get a response. Every single other one had a major response. And this is what a 95% response looks like. The tumor is pretty much gone. You can debate whether that little dot there is a vascular remnant or whether that's tumor. And that got into the New England Journal because we also noticed we had built in what happened to the radiation field, to the residual disease. When we went to RTOG with this protocol, they told us that it was unethical to deny these patients radiation because it's an effective treatment. And it's true, long-term survival with surgery and radiation does not produce very many people who die of craniopharyngioma, but it does produce a lot of people with other problems. And the BRAF-MEK pulls the tumor away from the optic chiasm and allows more effective radiation treatment to what's left behind. Most patients got treated with this for about a year. Toxicity was things like a rash that got better when the drugs were stopped. And we now have a number of patients who have gone off treatment and have refused radiation. And in only 1 has the tumor come back, and that one went away again with the drugs, and this time he accepted consolidation with radiation. So it may not even be necessary to use radiation for consolidation after this. Now, people say, well, you know, surgery and radiation are so good for this, why would you bother? Well, this is the most up-to-date report on gross total resection rate of papillary craniopharyngiomas. This is from 14 major centers, places like Danny Prevedello at OSU. These are people, Juan Ferrandis Miranda is among the authors here. Their gross total resection rate was only 50%, and 2/3 had permanent DI or hypopet. A significant amount of patients were readmitted or returned to the OR. If you do a gross total resection, what is the recurrence rate? This is Ed Law's series, published several years ago now, but I don't know why it would be any different now. 20% recurrence after gross total resection. So we say it's curative, but it really isn't. And the radiation is not so benign either. Again, this is modern treatment. This is reported 2 years ago, including proton treatment. 5% severe vasculopathy, 6 to 7% permanent visual loss. So there's a lot of room for improvement here. What we would like to do is get rid of the surgery entirely. And it would be great to have an imaging method, and we worked one out that it has an 80% positive predictive value, and in an external validation cohort. Cell-free DNA is what everybody would like to see work. We have not yet seen an untreated patient with positive cell-free DNA assays, either in serum or in CSF. So that leads us to endoscopic biopsy with or without drainage of the cyst, because basically the insurance company requires the molecular diagnosis to pay for the drugs, which are very expensive. Here is our primitive radiomics, age greater than 18 years, supradiaphragmatic, and no calcification on CT. You have to get a CT to use this. Has 80% positive predictive value. And there's also a difference in PET scans in that the papillary craniome is hot, adenomatosis is cold. And we're working on more advanced AI techniques for better radiomics. But as of now, Pam Jones is doing transforaminal endoscopic biopsies of these tumors when we think it's a papillary cranio, and then progressing directly to drug treatment without resective surgery. She's treated 5 patients so far. You say, well, one of those people only got one cycle. Like, how good is this really? That's all 5 patients there. That's tumor volume. So 97% reduction of tumor volume, which really brings into question the value of surgery in this disease because the complications have been essentially nil. Is that all you needed to do? We talked about whether you needed to consolidate with radiation or not, and this is an open question. And this is like a new thing for us. People are very resistant to this idea. But this, in the rest of cancer, this is an old idea. Since the 1980s, people have been treating laryngeal cancer, rectal cancer, esophageal cancer, and then shrinking the tumor down and then doing surgery if still necessary. So this is a very widespread technique, limb salvage in soft tissue sarcoma, just with imatinib in the abdomen. And we just haven't caught on to it, and I think we're going to see more and more like this. Here's another example, von Hippel-Lindau disease. Bill Kalin worked on this for years before his wife died of glioblastoma, and he really hates cancer. And you've all seen these patients. We saw some hemangioblastomas of the spine yesterday. This drug, belzutifan, the average volumetric response is about 50%. And that covers both the solid and cystic portions of the tumor, and the responses are durable. And the drug is, by and large, tolerable over long periods of time. Sometimes a dose reduction is needed. You have to stop this a couple weeks before surgery and don't restart it for a couple weeks afterward because it inhibits wound healing. In von Hippel-Lindau, it's very clear that each successive operation, the patient's quality of life goes down, as this bar graph here shows you. That's quality of life on the EQ-ED5L scale. People who've never had an operation significantly better than those who have had 2 or more. And this graph really tells the story. So this is the first prospective phase 2 trial of belzutifan for CNS-related tumors, hemangioblastomas. I don't think there are any endolymphatic sac tumors here. On the left, the gray bars, each blue dot there shows a CNS surgery that patient got. So most patients in the preceding 4 years got at least a couple of operations. And the little arrows on the very left-hand side show you which ones have had surgery even before that. And then the green bar shows the experience during drug treatment, and only 1 out of 50 patients needed an operation at all. I think 1 other patient got radiation for a CNS hemangioblastoma during that time. So those are great, but they're very rare. Most of us see these things very uncommonly. So let's talk about one thing that's very common in our practice, which is brain mets. And ever since 1990, the field has been kind of open for single brain mets, for solitary brain mets where there's nothing else in the rest of the body, and for dominant brain mets where there's one met that's causing problems and urgent surgery becomes needed. And then in the first decade of this century, SRS really became well accepted for brain mets with a survival advantage in patients with single brain mets. And so the standard of care for something like this, which is a 59-year-old woman with a single renal cell met, radioresistant, gets gamma knife treatment and has long-term success from that. In 2016 and 2017, we showed that the whole brain wasn't needed anymore, that you could get by with just radiosurgery to the resection bed and to other tumors. And so how about using some of these other drugs that I showed you? We haven't really talked about any kind of immunotherapy. Within 1 week after that BRAF-MEK paper for melanoma came out in the New England Journal, the next week this paper came out on checkpoint inhibitors. This is just IPI, but the modern treatment is IPI-NIVO, and it's rough. 3 or 4 months where you reject almost every part of your body, uveitis, everything inside your abdomen. It's bad. But on the other hand, the long-term survival from metastatic melanoma is now 50%. So these people get 3 months of double treatment, and then they go on just maintenance Nivo, and they live forever. So now our role has changed a lot in this disease. If necessary to make a diagnosis, you might think about taking out that one that's on the surface in this 81-year-old. But after the checkpoint inhibitors and no other treatment, 5 years later, he's disease-free in the intracranial department. 63-year-old, to take out that large one that's symptomatic in the right frontal lobe, and then no other treatment except checkpoint inhibitors. And this is his most recent scan from last month, 9 years post-therapy, no evidence of disease inside the head. This is what led to people like Jimmy Carter living for decades. He was one of the first people treated this way. And of course, he lived for something like 10 years and died of other causes at age 100. So there are a lot of common brain mets where this is now the way it is. Non-small cell lung CA if it's EGFR mutated or ALK rearranged, breast if it's HER2 positive, melanoma, colon if it's hypermutated. We have a trial open in this in the Alliance Cancer Group. But the things for surgeons to think about are two. One is you have to get the patient off steroids because these agents don't work as well if you're on steroids. And the second is you have to avoid radiosurgery because radiation necrosis is much worse with immune checkpoint inhibitors if you've had radiosurgery. So our role has really changed a lot. If necessary, do it to make a diagnosis. If at presentation they have a dominant or a critical lesion in the post fossa that's going to cause hydrocephalus. Otherwise, you just need to get them off steroids as quickly as you can. And immune checkpoint inhibitors can be started within days of surgery. There's no need to delay for wound healing. So these people are often started on post-op day 1 or post-op day 2, and that's the only treatment that it's likely that they're going to need. And I think I showed you this slide at the beginning with everything in black. So what's in red here, these rare tumors now have FDA-approved treatments that are in daily clinical use. The blue ones are things that we think are coming pretty soon, and there's one of those black ones that I can't tell you about, but if you go to SNO, you'll see Priscilla Brastianos present some very promising responses in one of the others that the drug company won't let us talk about. So that's what I had to say today. Happy to take any questions if we have time. But I wanted to make a slide. There's a butcher shop that's on Washington Street that has a sign on their roll-up thing that says the future is now. And that's really my message for you today, that we don't have to wait anymore, that this stuff is here now. Unfortunately, when I went out this morning, they had already rolled that thing up to go to work. But if you come back here after hours, I think you'll be able to see it. And that's my message. Thank you. Petroclival meningiomas? Yeah, we haven't. I didn't show it, but we have an open trial in the Alliance for several molecular subclasses of meningioma, including NF2, ALK, and we had smooth and open for a while. But the two successive drug companies took their drugs away from us. It is not the same. If it's working at all, it's going to be one of these things where it slows the tumor down. It doesn't make it go away. The thing about the craniopharyngioma is it makes it go away, and even if they have a visual deficit, it gets better. Sometimes the DI gets better. We don't have anything like that right now for meningioma, and even if the CAR T cells are good, I don't think that's where you would want to start with somebody who probably has a benign tumor. Those are usually benign, and if there's a little bit of swelling in those, it's probably not going to be silent. So I don't know where we need. First, we have a big funding challenge because a trial like that takes multi-million dollars, and then we haven't quite tuned up the design yet for who we'll start with. Probably malignant meningiomas in an area that is relatively non-eloquent.
Fred, that was beautiful. It takes a senior, wise surgeon to talk to us about reasons not to operate. The craniopharyngioma is life-changing, game-changing. As we all know, you never operate on those patients and have them end up being as good as you go in. And in terms of their hormonal status and things, like there's always something worse anytime you operate. And yet, as you showed, we've got these big consortium papers and everybody loves showing their operative videos. And so how do we integrate this approach into the neurosurgical community where neoadjuvant obviously makes so much sense?
People have to get used to it, I think if you think about clipping versus coiling, I think that the pace of that handover was people retiring and new people getting trained. Took probably 20 years, really. I mean, the midpoint of that was around 2005, I think, and we had started doing it about 10 years before, and now we almost never do open clipping of aneurysms. I know that differs from hospital to hospital. I mean, you got unregenerated people like Sander probably clipping everything still, but I think this will go faster than that. I think the real barrier here is that we are the only ones who see these patients. They come in to the emergency room or they are referred in to us. And when we first wanted to do that trial at the Alliance, we went to one of the world's best-known neuro-oncologists, Priscilla and I, and said, we want to do a trial on craniopharyngioma. And they said, well, yeah, I mean, your results sound good. It sounds like something we can do, but I mean, shouldn't we check with the head and neck people first? She didn't know that it wasn't here, that it was here. So neuro-oncologists have never seen these people before. The radiation oncologists see them, but the neuro-oncologists don't. So those kind of, and it's impossible to keep up with all this, with what's the latest thing for ALK mutated. You just have to get the people who live and breathe cancer chemotherapy every day involved before you normally would. And oftentimes they will have something that would not occur to us as a surgeon. And, we heard talks yesterday about multidisciplinary. This is exactly where that kind of thing will drive progress that makes people's lives better, because surgeons aren't the ones doing this work. We need to understand that it's happening and that we can benefit from it, but we're never going to do that. We're never. I go to ASCO every year. I've 30 years. I've only had one presentation. That's not our world. It's an amazing world. There are 40,000 people there, and the stuff that's happening in cancer outside the head is amazing, and we just need to catch up with that, which is great. We don't have to have our own ideas. We can just import this stuff, and it works. It's perfect. Thank you very much.